Very good evening. So we are going to discuss about the sentinel lymph node biopsy in breast cancer. So here we are going to discuss about the dual dye technique, indocyanine green and the blue dye. So sentinel lymph node biopsy, the concept was inducted by the Giuliano intraoperative lymphatic mapping and identified the sentinel lymph node using only blue dye. Thereafter, Craig investigated and they shown the use of radioisotopes for sentinel lymph node identification. After that, Albertini was the first to identify the sentinel lymph node using a combination of blue dye and radioisotope. Thereafter, Semen first reported the methylene blue dye could serve as an alternative to isosulfan blue. And as of now, there is a gold standard is blue dye and radioisotope in combinations. But over the period of time, indocyanine green has evolved, and right now this green gold is in highlight, and it might be the next gold standard ICG with methylene blue dye in most of the settings. So what are the different techniques? So conventional are the blue dye, radiocolide, blue dye plus radiocolide. It's gold standard as of now. Then ICG, emerging technology. Now we can say it has already emerged and evolved, and it's being practiced in most of the centers across the world. Other techniques are supraparamagnetic iron oxide, contrast enhanced ultrasound with microbubbles, and Sentimag. So what's a fluorescence guided surgery? So basically it's a technique used to detect fluorescently labeled structure during surgery. And it provides a real-time visualization of the operative field, so that actually helps the surgeon to find out the exact anatomy and to find out the target organ of the interest for surgery. What's a fluorophobe? Fluorophobe is a fluorescent compound that can re-emit light upon light excitation. So when we throw light on a particular substance, then it absorbs and throw it back. So examples are indocyanine green, methylene blue, 5-aminol levulinic acid, then fluorescein sodium. So these are the different compounds that can be used as a fluorophobe. And ICG actually it has high contrast and sensitivity because the near infrared light used to measure fluorescence makes tissue appear more translucent, so they are more visible. Its depth of penetration is 2 to 4 mm and usually excited between 715 to 800 nanometer. And it usually comes in the powder form, and we need to reconstitute it with aqueous sterile water, the pH of 6.5, and it has quick clearance rate. It clears very quickly from the liver and usually have half-life of 3 to 4 minutes. So how this imaging system works? So NIR light source, it's a LED or laser light. Uh, there's a different components: NIR light, NIR fluorescent agent like fluorophobes, then imaging system, excite and detect fluorophore. Then NIR can be combined with white light and red, blue, green spectrum for real-time anatomical visualization. So there are a lot of things that we can see. So in this picture here, you can see there is the light source. This is the NIR camera. So light is thrown from the hair to the target organ, and dye is injected into targeted for the targeted organ. If in breast, then it can be injected directly, or if we are seeing the perfusion assessment of the flaps, then through the IV. So light is thrown from here, it excites and the picked by near infrared camera. So this is the how it works. This video is actually shot on Striker SPY-5 system. So this is the console, it is the processor monitor, and this is the handle device. So from here you can manipulate the system. You can change between the different modes of the camera, and this is the dye oro green that we are using currently in India most of the time. It usually come in 25 milligram. It's powder form. So we reconstitute its 10 ml of saline, 2.5% solution. So for this axillary sentinel lymph node biopsy, we should be aware about the different anatomical position of axillary lymph node. So this is the classical anatomical system. Level 1 is lateral to the pectoralis minor muscle, level 2 behind the pec minor, and level 3 is medial to pec minor muscle. So the level 1 is lateral to pec minor, and this is the area of interest. So most of the time sentinel lymph node is located in the this anterior group of lymph nodes. So it's Lee classification system, another system. So here intercostrobrachial nerve brachial nerve divides the upper axilla and lower axilla. So in lower axilla usually find sentinel lymph node, and is the most latest classification of axillary lymph nodes. Here, this is the zone A, that is the medial to LTV, long thoracic vein, and below the intercostrobrachial nerve. So this is the area of interest. Here you need to look for sentinel lymph node, and most of the time we will find sentinel lymph nodes here. And this is the photo of axillary dissection. Here we have preserved most of the axillary nerves. This is the second intercostal brachial nerve. Here you can see the long thoracic nerve, thoracodorsal artery vein and nerve, and this is the axillary vein. And this is the pec minor muscle. Here you can see this pec minor muscle. Just below that pec minor muscle, you can find out the sentinel lymph nodes. So this is the video of sentinel lymph. So in this particular case, actually, we have done sentinel lymph node biopsy by dual dye technique. It's a post-NSCT setting. So patient has received neoadjuvant chemotherapy, and after that, we are assessing sentinel. We are doing sentinel lymph node biopsy. So 2.5 centimeter size tumor that's completely vanished. Now we are injecting the methylene blue dye. We are injecting subcutaneously. So you can go a bit deep. Usually avoid to inject methylene blue in the skin. Don't give intradermal injection, otherwise it may cause the skin necrosis. So go deeper. So you can give at two sites, at 3 o'clock position if you are doing on the left side, and 9 o'clock position, 1 ml at each site. And then after giving the injection, do a good massage in rollout way. So from nipple towards the axilla, do it for at least 7 to 8 minutes or 10 minutes. That would be better. This is the ICG. That should we usually give this intradermally, 0.05 cc. So here you can see you should be very careful. There shouldn't be contamination of the field. And while you are injecting methylene ICG dye, then there should be the bleb, raising of a bleb here you can see, and take out very gently without any spillage. Again, at 12 o'clock position by similar technique. Once you have given, immediately with the help of this spy system, you just put your camera 25 centimeter away from the target organ, put the monitor just in front of you as we do in the laparoscopy. So here this is the color segmentation mode. This is the fluorescent mode, spy mode. This gives the maximum sensitivity. And this green mode is when white light is combined with the fluorescent. This is the overlay mode. So here you can see the anatomical picture along with the fluorescence. So if you are doing real-time surgery, real-time navigational surgery, then overlay mode is quite helpful. And this red, blue, and yellow zone, actually red is the area where maximum concentration of ICG is there. And so immediately after giving the dye, we can see there is a trickling of ICG into the lymphatics and it's going towards the axilla. So that's a beautifully seen lymphatics that's going towards the axilla. And you can actually find out the point where exactly it's dipping into the axilla. And just wait for 5 to 7 minutes. Then you can again see you may go beyond that particular point, and that can give you a new point of dipping into the axilla. So just mark the point. So here you can see earlier we picked the 1 point, then there are 1 centimeter away. So it's just below the axillary hairline. So that's the point. And after that, you are not able to see the fluorescence. So this is the drawback of ICG of this particular system. You cannot see beyond the depth of 8 to 10 mm. So it's not very helpful in very obese patient or something when there is a lot of subcutaneous fat that it may misguide you. So in this particular patient, non-obese patient, that's a drawback of ICG. So you can find out the point where the axilla lymphatic is draining into the axilla, then place your incision. So usually 3 to 4 centimeter size incision placed in the lower axillary hairline. And as we do the sentinel lymph node biopsy, just deepen your incision, cut the subcutaneous tissue gently. So actually, it's a sentinel lymph node biopsy is a minimal invasive procedure where you shouldn't damage much of the axillary tissue. So here you can see after breaching the subcutaneous fat and dividing the clavipectoral fascia, you can just see the fluorescent in the axilla in the screen. In the monitor, you can see there is a fluorescence. So you can see the fluorescence in the monitor. Then uh, just gently delineate the tissue, and in the real time you can see over the monitor that fluorescent is there. So while digging into the axilla, be very cautious, because if you injure any of the lymphatic, then there is a lot of spillage of the ICG dye, and your entire field will be doomed. So then it will be very difficult to identify these sentinel lymph node. So in this particular, it's post-NSCT setting, and we have injected dual dye. So here you can see this blue lymphatic. This is the blue lymphatic that draining towards the lymph node. So you can just chase the lymphatic. So before chasing, just clip the lymphatics and divide it. So it will not contaminate your axilla, either by blue dye and ICG. So we found a small lymph nodes. It's not blue and it's not very fluorescent as well, but it encountered in the path. So we just remove this node. It might be or might not be, as it's a post-NSCT axilla. It might or may not be sentinel lymph node. So there was limited fluorescence. We kept this for frozen section. Again, we target the axilla, and we see a lot of fluorescence is still there. And again, dissect very gently with the help of right angle. And again, here you can see there is a lymphatic and there is a blue dye. So this is the color segmentation mode. Here you can see there is a redness, a deep intensity of fluorescence, and that's a lymph node where both blue dye and fluorescence is there. So it might be. So again, we clip the lymphatic so that it will not contaminate the axilla. Then divide the lymphatic and take out the lymph node gently. So here you can see blue lymph node, and it's fluorescent as well. We have checked with the color segmentation mode as well. Yes, here in this spy mode or fluorescent mode, you can check it again and again. This is fluorescence. This is overlay, white light with the fluorescence. Then this is the color segmentation mode. So we have confirmed that this node is blue and fluorescent, and then we take it out and we clip the lymphatic. So it's very important to clip the lymphatic. So this is the disclaimer while you are using the ICG dye. Always clip the lymphatics. Otherwise, there is the discharge of fluorescent ICG dye from the lymphatics. It will ruin your field. Then you will not be able to find out any other further lymph nodes. So here you can see there is a intense fluorescence and there is a very limited fluorescence in the periphery. This is a color segmentation mode. So in this you can very well appreciate that in the fatty part there is a limited uptake. So you can just remove that particular part with the help of scissor and can send the actual fluorescent part for frozen section. Again, so after sending that particular node for frozen section, again go into the axilla, dig it up, dig very gently into the axilla, check with the fluorescence. If there is no further fluorescence or blue dye or any palpable node, then that completes your procedure. So another advantage is the quantitative analysis that you can do by this Striker system, that you can set your device with 100% at the point where you have injected the ICG dye, and as a representative, or you can do the quantitative assessment. You have considered the 100% at the injected site, then you focusing on the axilla by this square box, and then you can see if there is no further fluorescence in the axilla, then it's complete your procedure. So this is how you can ICG and methylene blue dye. So we have a study to 2021, a pilot study evaluating the sentinel lymph node biopsy using dual dye technique with ICG and methylene blue. And we found out by combination of dye, there is the false negative rate is less than 10%. It's 8% in our study. And ICG alone, it was 95% identification rate. And by combination, it was 97.5%. So there is a lot of other use of ICG in breast surgery, skin flare, myocutaneous sentinel lymph node biopsy, axillary reverse mapping, lymphedema assessment. So these are the other advantages. So sentinel lymph node biopsy you can do by methylene blue dye if you are working in a new setup, but there is the identification rate is around 80 to 90%. So you need to be a bit expert in injecting the methylene blue dye and do proper massage, but it's doable and you can start your practice with the methylene blue dye. If you have the facilities of radiocolloids, then you can use combination of dye, and if you have the facilities of ICG, then either you can go with the ICG or with the help of ICG plus methylene blue as a combination. And it's you can use in post-NCT setting also. So it's constantly evolving. It's a surgeon dependent procedure. You not to be dependent on the nuclear medicine person, but swift planning of procedure is very important. And single dye in upfront setting, more than 90% identification rate and less than 10% of false negative with single dye, particularly for ICG. Thank you so much.